also, as a doctor in the VA, and I understand you're not just one of the regular doctors, you're one of the head doctors there at the VA that you work at. How has your job changed with this COVID-19, since I understand that is one of the big things that's on people's minds right now is COVID-19? One, I guess we'll go with the question that I first asked you is, how has your job changed since COVID-19 has made its way into our country?
Well, in the sense, a doctor's job doesn't change. He sees patients, right? It doesn't matter whether they're infected with a virus or whether they're having appendicitis or whether they're, slip and fall down and twisted their ankle. You're still going to see patients. So the fundamental job hasn't changed. I still see patients. The thing that's interesting is, because I'm an urgent care doctor, right? I transferred from primary care to be the director of an urgent care up in Marion. So I'm up there in the urgent care center right now, and really, since the COVID outbreak, I don't do much anything because urgent care and emergency room, their visits are down probably 75% because nobody really wants to go into an emergency room that's infected, right? We're talking about a virus that has a death rate about 9 to 10 times what the flu is a common death. There was like a 0.6% death rate for the flu, and this is almost a 2% death rate. But of course, you can make the argument we don't know really how many people are infected with COVID. There could be a lot of asymptomatic people, and that's true. But still, with the fear out there that this thing, can happen all of a sudden, it can come on suddenly, and you're on a ventilator, that really is a deterrent to people coming in to see you from an urgent care and ER standpoint. So we went from seeing 20 people a day to like 5. So really the biggest thing that's changed from a acute medicine standpoint is people aren't coming in. And that's kind of sad in a way because you're seeing a lot of deaths now, and they're probably heart disease related more than they're COVID related because instead of coming to the ER, they're dying at home. So you have a lot of indirect COVID deaths, and there's been an argument made, and I believe it could be a decent argument that, some of the deaths that we think are related to COVID really are unrelated. The one thing that's changed about our profession as a whole is the telemedicine. Everybody's going to telemedicine now. We're going to urgent care, so we're having a protocol for video visits like what I'm doing with you right now. Those are going to be the new norm. Your doctor's going to call you up. He's going to say, hey, let's do a video chat. And that's kind of going to be how it is for a while because nobody really wants to come in, and doctors certainly don't want to see you if you're symptomatic. They would rather have you go to a drive-in testing facility and see whether you have the COVID or not. So that's kind of changed dramatically in the past month or so.
But also, could you tell me what does COVID-19 stand for?
Well, COVID-19, that's coronavirus infectious disease or coronavirus disease 2019. So corona is Latin for crown, right? So you have this virus that's shaped like a crown. It's a ring-shaped structure when you see it under a microscope. So that's where the name corona comes from. It actually was discovered back in the 50s. It's a cold virus. It caused the common cold. So when you looked at back in the 50s and 60s identifying this thing, you saw these little crown, little ring-shaped virus particles, and they termed it corona, meaning crown, and that's where the name came from. And so this is not a new virus at all. It's not anything that we didn't know about before. It's caused the common cold, been around for decades. The thing that really was difficult was the fact that this was a mutated, novel, new strain. This strain nobody had antibodies to. Actually, the name of the virus is SARS-2. COVID is the name of the disease. So you have COVID, you have coronavirus disease 2019, but the actual virus name is SARS-2. So when you look at this virus, it's identified by the SARS because that was also a coronavirus. But this is a new strain. So we have to be careful in what we develop and how it's going to be effectively used and how long it's going to take for safety. So that's why you have kind of a conundrum in treating a novel virus, because you're developing antibodies and you're trying to make a vaccine while the antibodies are still being developed to a virus that could potentially mutate, and then your vaccine isn't effective at all.
Wow. I've been wondering about that because we keep on hearing different symptoms. So what you're saying, it could be just different strains.
Yeah, it's a typical upper respiratory infection. You've got cough, usually dry cough. You've got fever, 102, 103. You can have a runny nose, and then they've thrown in some new ones. They've thrown in headache. They've thrown in GI, diarrhea, gastric symptoms, sometimes nausea. Fatigue is very common, and then general malaise, your general body aches, called myalgia. You get that with your typical flu-type viruses, right? So this one causes what they call the flu-like illness. You've got the myalgias, you've got the fever, you've got the feeling like a truck just ran you over, and then you've got this cough. So here's the dangerous part, right? So you get these symptoms usually on an average of 5 to 6 days into the virus. Anywhere from 2 to 14 days, you can just be carrying this thing around. And then all of a sudden, bam, you get this flu-like illness, you get this cough, you get this high fever, you get these worn down myalgias, aches, pains, all that stuff, and then all of a sudden you get better. And that's when the storm hits. They call it a cytokine storm. Cytokines are chemicals that your body makes for one organ or one tissue to talk to another, okay? So interleukin-1, interleukin-6, these are called cytokines. It's how cells in your body communicate with each other through these chemicals. Well, these cytokines, they go crazy in your body, and they start to develop this cytokine storm, which then leads to direct toxicity on the lungs. They start to destroy your lungs. So you started feeling better, you develop this immune system response, and then the immune system goes crazy. And the next thing you know, you're starting to be on the mend, and you go into complete respiratory distress, and you're on a ventilator. So these people with chronic diseases are more prone to get into that state. But the fact of the matter is, we don't know, because it's not that simple. There's 37-year-olds that are dropping dead, and we don't know why. So that's what makes this thing so scary. You didn't see that with flu. With flu, you kind of knew the really young kids and the really old folks, they get really bad. This one is kind of non-discriminatory, you know what I mean? And so it's pretty scary out there for some folks.
So basically, it sounds like you're saying no matter what your age, if you're feeling as though you have those symptoms, you need to make sure that you get tested so you can start getting help immediately.
Well, yeah, not necessarily. If you don't have a fever, just stay home. Just stay away from people, because it is true the majority of the people, right, they recover. A death rate of 2%, by definition, 98% of the people are getting better, right? So rather than, waste all of our resources testing 300 million people, which isn't very feasible, we should be fairly discriminatory on who we test. And a lot of times it has to do with your symptoms. If you're getting a high fever, if you're getting a dry cough, if you're short of breath, and you have been around somebody that you know was COVID positive, then yeah, you're the guy who needs to be tested. So, my advice to you is, number one, stay home. Number two, if you're sick, stay home. Number three, if you're sick, you have a high fever, and you've been around some of the COVID, go get tested.
So, you work at the VA. How has it been getting PPE, the protective equipment that you need?
Well, we use M95 masks, and those are pretty effective. You see, the problem is walking around with these surgical masks, that's not a bad idea if you're coughing, because the surgical mask can help trap some of that particulate matter that you happen to be spewing out all over the place, right? So it's like covering your mouth when you cough. So if you're walking around with a mask because you're coughing, you're going to greatly reduce the risk of transmitting a possible COVID to other people, because your respiratory droplets are being trapped by the mask, and you're having a lot less virus particles coming out. But as far as COVID going in, well, the pores in a surgical mask are probably 2 to 3 times at least the size of a virus particle. They just go right through. It's, the virus is going to be around. It's going to get better. Viruses don't live forever. I mean, they have to infect the host. Once we get enough herd immunity, then there's no host left to infect enough to propagate the virus. It's a simple, math equation. Once you get down to enough people being immune to it, the issue, of course, is mutations of the virus, and how do we get people immune to it without causing a huge increase in death rate from those that are at risk? Because the people that are vulnerable, the at-risk people, are the people we're trying to protect the most right now. Once again, if you're talking about a death rate of 2%, you're talking about a health rate or a recovery rate of 98%.
Well, thank you very much, Dr. Barber, for coming on here and, one, telling us about your military experience, but then also telling us a little bit more about COVID-19 and how we can protect ourselves. So thank you very much.